So in a brief manner, I've come to talk to you about another of the elements likely to be in Barnsley Quality Framework's basket from April. And I want this to be interactive if possible, because I'd like you to have some contribution as to how we bring in these follow-up arrangements. And I want to let you know what sort of support we think the CCG can give in the sort of transition phase. So I haven't put who I am, etc. on the slide, because I think most of you know me. I'm Colette Leese, and I work 1 day a week for the CCG to support the Cancer Programme Board, funded by Macmillan. And these slides have also been contributed to by Sabir, because she thought they were a little bit too long in some cases. And so she's done a pruning job, mainly to take out my evidence base, like where I got my figures from, etc., which does make them a bit more readable. So both prostate and bowel cancer are common, and Barnsley has a very slightly lower incidence than nationally for prostate cancer, but we have a poorer survival rate than nationally. In Barnsley, the 5-year survival is only 65%, whereas Cancer UK's prediction for people diagnosed from 2010 onwards is that they would expect 10-year survival of at least 84%. So we've got a little bit of catching up to do, and Russell may like to comment on that when in the questions if you want to ask him. Colorectal cancer, similar incidence to nationally, another common cancer at 49.5 per 100,000 in the population incidence annually, and 5-year survival very dependent on staging at diagnosis, with very good survival of 93% if you're stage 1, and I haven't even put the figures for stage 4 and 5 because they are very low, and gradually decreasing survival with advancing stage. We are hoping that more diagnoses in future will be stage 1 as the screening programme is ramped up from just a fecal occult blood test to sigmoidoscopies for the over 55s. But we'll find out with time whether that, whether we do see more stage 1s. So basically, who is recommending that the follow-up be moved from secondary to primary care? And the answer is NICE, backed up by the local cancer networks and the strategic groups that have replaced the cancer networks in the latest NHS reshuffle. And what are the recommendations for bowel cancer follow-up? The recommendation is that follow-up ceases at 5 years. But in the period leading up to that, there are serial CT scans, serial CEAs, and repeat colonoscopies. So 2 years after colorectal cancer, patients who have no evidence of recurrence, no evidence of metastases, will be discharged to GPs if we get this together for the Barnsley Quality Framework. If patients obviously have signs of progressive disease, they'll remain in secondary care, and they'll only be discharged at 3 years if they've got a rectal cancer. The reason for that just being that there might be some benefit in doing digital rectal examination, and we're not expecting GPs to become more skilled in that area, and so rectal cancers will remain 1 year longer in secondary care. So if, in general practice, we're monitoring these patients, we would be monitoring their CEA and their general health, and asking about whether they had developed specific symptoms that could relate to a recurrence. And if the CEA rises above an agreed level, then we would re-refer. So colorectal symptoms that might cause concern, none of them I don't think are any real surprise. Change in bowel habits. They may well have diarrhea ever since their surgery, so we'd only be interested in some change from what had become normal for them post-operatively. Abdominal pain could be anything, so, you know, I'm not saying that you would refer back every single new abdominal pain. You would make a clinical judgment. New rectal bleeding, And again, the next symptom I put is abdominal or rectal mass. We're not expecting you to routinely be doing rectal examinations, but if the patient reported that they felt that their abdomen had increased in size, then we would expect a clinical examination and appropriate action. Unexplained weight loss, unexplained anemia. Most of these patients, many of these patients are going to be in the age group where they've got multiple diseases, and there may well be other reasons for their anemia. They might be long-standing, and you might not feel you needed to re-refer. But in the cases where it's new, then it would be appropriate to re-refer. So we need to educate your staff. I am expecting that this follow-up will be nurse-led, and that we will try to provide a template that guides the nurses through the sort of questions to ask and allows them to easily document in a way that will leave everything read-coded, so that it can be compared if someone else is seeing them in the future. There'll be 6 monthly appointments, and at 5 years, follow-up ceases. You'd ask about their general health, specific symptoms, and do a CEA. And the discharge summary should point the clinician towards what level of CEA would trigger re-referral. And re-referral would not be via the 2-week wait, because we already know these patients have had bowel cancer. Referral would be an urgent thing to a bowel specialist. So prostate cancer follow-up is a little bit more complicated, because many of them are on androgen deprivation therapies, which may or may not be for life, and follow-up is for life, because many patients have their disease controlled, and we know we've not cured them. So again, NICE and the local cancer networks are advising that we discharge patients from secondary care 2 to 3 years post-diagnosis. There's a whole range of treatments they might have, and a whole range of stages that they might be at. But the NICE and the local cancer networks have decided that many of them will have a long period of stability on the androgen deprivation therapy, and that by monitoring their PSA, we should be able to refer them back should the treatment need changing, should further treatments need to be considered. So NICE were recommending a serial PSA every 6 to 12 months. It should be clearly in the discharge letter, how frequently the PSA is to be monitored, and we will want practices to audit to have robust clinical governance to make sure that people don't slip out of the net and remain unmonitored. And again, re-referral to a urologist if there's concern. If the PSA is rising, it's pretty certain that this is progression of their disease, and so not just an urgent referral, but a direct letter to the MDT will be the route that we'll suggest for acting upon a patient whose condition is no longer controlled. So, how to interpret the PSA in prostate cancer follow-up. 3 successive rises, if the doubling of the PSA from its lowest level. So either of those things. And also if their symptoms suggest bladder outflow obstruction, so we've already had several people mention today what the symptoms of obstruction are: hesitancy and poor stream, etc. If it's bad enough to need treatment, and obviously if they develop bone pain and you suspect that they've got metastatic disease, the spinal cord obstruction, etc. The most bony metastases being particularly common with prostate cancer. So secondary care's role will be to identify the patients, discuss it with the patient, and send the GP a suitable letter, particularly detailing the androgen deprivation therapy in use, how frequently it needs giving, which is a subcutaneous injection, most of them, and the duration. Not everyone needs medication because some men will have chosen to have an orchidectomy, and not all treatment will be lifelong, but many of them will be. We need details of current and previous PSAs, required frequency of testing, and advice about, just to confirm what level should provoke re-referral. So we need good recall systems, we need trained staff to give the androgen deprivation therapy. We need protocols and templates to help. And we don't need you to be doing digital rectal examinations. We need there to be some flexibility in the system because, particularly with prostate, with the PSAs, they're suggesting that we would refer if there were 3 raised within a year. So you might want to bring forward the appointments to be a little bit more frequent than 6 months in order to get 3 tests done within a year. We need robust clinical governance, and we need adequate funding, and I have tried to stress that bit to the CCG, because we are looking at a fairly unknown quantity in terms of the ageing population means that we'd expect more prostate cancer in the future, and the prognosis is improving with the figure I gave you of over 80% 10-year survival. We could be talking about every general practice monitoring a large number of people. And so whether the quality framework looks at cost per case or a single payment might become of more importance in future years as the numbers build up. We're expecting initially that we might have, in the first year, when it's been running 12 months, about 80 men discharged completely from urology follow-up across the whole of Barnsley. So that is not very many per practice, but when that's continued year on year, it's going to become more significant. We also initially wish to support practices by negotiating with Russell that nurses or doctors can phone him if there are problems in this transition period particularly. And obviously, as with all of our consultant colleagues, you're still going to have the option of contacting a consultant direct for advice regarding management. So we're in discussions with the people at the CCG who are drawing together the Barnsley Quality Framework. But there are a few issues that we need to work through, which may slightly delay bringing us all on board. Medicines Management think that they'd be happy to recommend that the androgen deprivation therapies are reclassified. As you know, they're on shared care at the moment, and they'd have to become so that GPs would not be expected to initiate them, but that we could assume responsibility for follow-up. Template development, there's a lot of pressure on the IT team who are part of the CSU, and they're not willing to give me any timescale whatsoever or even agree that they would help me to do any template development. So time will tell whether I get whether I am able to get some support there. And secondary care, we have to agree a timescale with them for identifying patients. And obviously the financial funding, the financial aspects of it have not been fully worked out to with it being slightly more complicated as well, that some patients will be having both medication injected and PSAs, and others may not have it, will just have the blood tests. So I expect it to roll out sometime in the next financial year. So that was short and sweet, but I think it gave you, hopefully, some information, and it may generate a few questions and a bit of discussion.